Welcome back, everybody. Thank you, Senator Padilla, for that wonderful presentation. As you all may know, Senator Padilla was born and raised in Pacoima, so he has a personal connection to the San Fernando Valley. Thank you also to Sarah and Alejandra for the Q&A and to Alejandra for the presentation. Our second presenter is coming up right now. Her name is Daisy Rosales. She's a licensed marriage and family therapist and a clinical supervisor at El Centro de Amistad under the Family Preservation Program. Daisy earned her bachelor's degree from California State University, Northridge, and her master's degree in marriage family therapist at Phillips Graduate Institute. Ms. Rosales has worked at El Centro de Amistad for 6 years. She worked initially as a mental health clinician and now is part of ECDA's management team. She enjoys working with underprivileged communities and families. She is trained in several evidence-based practices, including TFCBT, CBT, and seeking safety, and has an expertise in working with clients who have experienced trauma, anxiety, depression, high-risk issues, relational difficulties, and challenging life transitions. Through her own personal lived experience and growing up in the same community in which we provide services, she's able to relate and connect with others in an impactful and helpful way, which has made her work more fulfilling and rewarding. Daisy will be presenting today on suicidality and adolescence with cultural considerations, interventions and treatment, and crisis and safety planning. This is a very sensitive topic, so if you need time to regroup, please give that to yourself. Please join me in welcoming Daisy Rosales. Thank you, Daisy, for taking the time to present today.
Hello, everyone. Thank you so much for that wonderful introduction, Tanya. I appreciate it. And thank you, Alejandra, for that wonderful presentation as well. And I will go ahead and share my screen now. So give me one moment. Okay. Just want to make sure you all can see my presentation. Can somebody confirm? No? Okay, give me one moment. All right, there we go. Thank you so much. So once again, thank you so much for joining us. And I will be talking about suicidality and adolescence. So as we already know, this is a very sensitive topic, and but definitely it's something that we definitely want to be able to talk about, especially during these times of COVID and post-COVID pandemic is something that's really important to be able to talk about. So thank you so much for joining us. So let's talk about it. Let's talk about a difficult topic today. So death by suicide, what is it? So suicide is death caused by injuring oneself with the intent to die. And a suicide attempt is when someone harms themselves with the intent to end their life, but they do not die as a result of their actions. And suicidal ideation refers to thinking about, considering, or planning suicide. And the reason why it's important to really consider the difference between these is because sometimes clients or patients may throw around these concepts, right? As to like, I want to attempt suicide, or I have thoughts of killing myself, right? And we want to be able to identify what it is that they're feeling, what it is that they're thinking about, and be able to pinpoint what is the best way to help them. So what are some of the warning signs for adolescents? We want to really think about what are some of the things that come up with any clients or any of our children as well. We want to be able to recognize what it is that they're going through in order to know when we need to check in. Personality change, withdrawal, substance abuse, reckless behavior, changes in sleep. So making sure that they are being able to sleep well, neglect in personal appearance, physical pain, and really kind of like, I think the biggest one that I would really recommend really checking in with is hopelessness about the future. What is your adolescent really dealing with? Sometimes I think like really listening to the words that they're using. Are they really seeing that there's no hope for the future? Nothing's going to get better. Same thing with sudden mood changes. Are they constantly like angry or all of a sudden angry or withdrawing from their family, from their friends, something that they're really enjoying? Are they in sports and really just not wanting to engage anymore? So those are some of the major warning signs that we want to look out for. So some statistics and facts that we want to consider are in the United States, suicide is the second leading cause of death among 15 to 19-year-olds in that age range. Prevalence rates of suicide attempts are higher among females versus males, but males are more likely to die by suicide. And the reason being that they tend to use more lethal means of suicide. Students who are identified as being gay, lesbian, or bisexual in comparisons to students who identified as heterosexual tend to have a higher prevalence rate of suicide, and those in the African American ethnic group as well. Some of the methods of suicide are firearms, which are the leading suicide method among US youth, and it's also followed by hanging and suffocation, as well as self-poisoning. And self-poisoning is more like taking pills and taking a large amount of pills to poison themselves. So in looking at the suicide rates for adolescents, and this is data or preliminary data for 2020, we can actually see a map of the United States on the left side. And we can actually see that at least in California, right, there's about 9 in 100,000 adolescents ages 15 to 19 died by suicide. So it doesn't sound like a lot, but you're talking about 9 in 100,000, and that's in the whole population. So when you really think about the whole country, I mean, that's quite a bit of adolescents, and it's a pretty alarming rate. And here we can actually see the suicide rates for adolescents by gender and race as well. So in females, we can definitely see it's about 5 in 100,000, and that's in ages 15 to 19. And in males, it's about 16. So that's about triple the amount of females. And on the right side, we're able to see that American Indian and Alaskan Natives are the highest risk and tend to die by suicide a lot more than other ethnicities, and then followed by Caucasian, Asian, Hispanic, and then African American. Some of the cultural considerations that we want to take in treatment are the language barriers. So one of the things that we want to really think about is, are they receiving services or are they available even in their language? Sometimes clients aren't able to access services in their own language. And that's something that kind of drives them away from even seeking. Sometimes if they just came from another country, they may not know how to even access those services. And that's where outreach is really important for us as providers. There's also the distrust of providers and the stigma in seeking help. As we already know, there's a lot of stigma with different ethnicities and different cultural beliefs, right? Of like distrusting providers, like we don't trust other people, and we keep these issues kind of like within ourselves. So that's one of the biggest things that also comes with seeking treatment. And also the belief in alternative medicine. So sometimes not really seeking mental health services, but really kind of thinking about it as, hey, let's look into our faith community, or maybe like we know a healer that can help us, and keeping it really within the family or within their own community that they know. So those are some of the things that we want to consider, and we want to be sensitive to that as well with our clients when working with them. So some of the differences among cultures. So in the Latino community, we know that females can be a little bit more expressive in the way that they express their feelings. They tend to be able to show their emotions a little bit more, while males have a little bit more difficulty doing that. And when they do so, they tend to be a little bit more aggressive, kind of a little generalizing there, right? But it tends to come out that way a lot more. And they tend to be a little bit more acceptable in those behaviors. So also kind of known as machismo. And there's also a high stigma in seeking mental health services. So, yo no estoy loco, I'm not crazy. The psychologist or the therapist is crazier than I am. Like, I'm not going to go see them. And so I think that that's something that really comes up in the Latino community. Immigration and acculturation issues. This is something that could be a really big one when it comes to adolescent suicide. The adolescents tend to grow up here in America while their parents are still trying to get accustomed to our culture here. And so that could lead to conflicts within family systems and trying to really help them get to the same norms and values as well. And something else to really kind of consider is familismo and familism. With the Latino community, there's a large influence in regards to a sense of family. It really influences the sense of individual identity, but there's a very big emphasis on family unity. We do things as a family, we respect our parents, and we respect our elders. So that's something that really tends to come up a lot with this particular community. In the African American community, there's a lot of racism and discrimination, as we already know. And that really is associated with a lot of depression, increased substance use, and hopelessness among African American adolescents. There's also a lot of social and economic inequities among this population. And there's a lot less opportunities for education and employment as well, which can also contribute to suicidality in adolescents. We also know that there's a lot more violence in the communities in which they live in, and there's a lot less community and family support. So these are some things that we want to consider when working with this population. And in the Asian American community, so there's a lot of discrimination as well, and there's acculturation issues, which are risk factors. They are much less likely to utilize mental health services in the Caucasian community. And I think that that's also part of kind of like what we were talking about with the Latino community as well. There's a lot of stigma and shame in being able to access services. They tend to also focus a lot in the family relationships, but there's also a lot of conflict as well in the family relationships. There's also a high focus and pressure to academically perform. So there's also that, and that can also lead to a lot of the suicidality and kind of wanting to make the family happy and be on par as to like the expectations for the community. So in really thinking about treatment interventions and what we want to work on with adolescents and whatnot, we want to really be able to engage the family in treatment. So one of the biggest themes that I have found in working with this population in adolescents is really engaging the family. As counterintuitive as that sounds, right? Like the adolescents don't really want to be involved with their family. They don't want to have anything to do with the parents sometimes at that age because they want to be independent. It's also very important. They need to be able to ensure there's a safe environment for their adolescent, and they have to monitor for safety in the home. They also may be able to help in resolving family conflicts. So you want to be able to engage the family in being able to help them resolve their differences and help them communicate a little bit better. There's also psychotropic medication. So this is a medication that they can, definitely see their psychiatrist for. Not that medication is going to stop the suicidal ideation. However, it could help with addressing any of like the underlying depression, anxiety, or underlying issues that may be leading to having suicidal ideation. So it may be able to help with those things. There's also dialectical behavioral therapy, and then you've probably heard of that before. But this one actually focuses on adolescents. So being able to help them on these 4 core areas. So building their mindfulness practices, interpersonal effectiveness, emotional regulation, and distress tolerance. And basically what those concepts are is being able to help your client or the adolescent being present in the moment, learning a little bit about how to do like deep breathing, how to live in the moment versus, thinking necessarily about the future and what's coming. Being able to set limits with others, setting boundaries, being able to recognize their feelings and how to sit with their feelings, the uncomfortable ones especially, and being able to cope with stressful events. So being able to help them really cope with those events that maybe they can't control. How can they cope with them and manage them, being able to move forward. There's also attachment-based family therapy. So as you can see, family, including the family is very important when it comes to suicidality in adolescents. They tend to, at least in this particular modality, they tend to include the family initially in order to help them build the connection with the adolescent. And then at some point, it switches over to building autonomy individually with the adolescent. So it initially starts with the connection with the parent, and then it moves on to being a little bit more independent from the parent. There's also the family intervention for suicide prevention, and this is a brief intervention. It's more usually used in emergency departments. There's a collaboration between parents and adolescents as well. So as you can see, this is kind of like a theme that continues to come up. And they conduct a crisis therapy session before discharge, which actually helps them be able to safety plan, develop skills for decreasing suicidal behavior, so helping them develop any like coping skills. And then it helps them have any like linkage after discharge to motivate, support, and ensure continuity of care. So one of the things that we want to make sure as providers is that our clients have that continuity of care and that we don't just discharge and we don't know what happened to this client. Something that's very, very important. And then there's Columbia Suicide Severity Rating Scale, which is the CSSRS. And this is actually a tool that assesses for severity of suicidality. And it actually assesses in 3 areas, which is the suicidal ideation, intensity of ideation, and the suicidal behavior. And here's a little bit of an example as to kind of what the tool looks like. This is not the whole tool. It's actually a kind of a lengthy tool, but it's a very good one where it's very specific. It really asks some questions that sometimes I think people are afraid to ask, like, do you wish to be dead, right? Have you thought about being dead? Would you like to be dead? And I think that sometimes we tend to kind of tiptoe around that and say, like, do you want to hurt yourself? And that can mean a lot of different things. So I think this tool is really helpful in really being able to ask the difficult questions in order to get a very thorough assessment. And you can actually find it online. You don't have to have any formal training for it, but you definitely should get acquainted with it before using it. So in talking about crisis and safety planning, so these are some important things to kind of keep in mind when you are getting ready to safety plan. So again, engaging the family in the safety planning process. You want to make sure that the family is on board in monitoring and helping the child or the adolescent stay safe. You want to help in reducing the family conflict. So a lot of the times, the things that are going on in the home are causing the suicidal ideation. So making sure that you facilitate the communication a little bit more and help the family work through that. And discussing the importance with the family of taking suicidal thoughts expressed seriously. So making sure that they don't minimize. Sometimes we hear from parents like, oh, they're just looking for attention. You know, they're just teenagers, that they're not being serious. So making sure that they're not minimizing what they're saying. And making sure that we provide a psychoeducation to not only the adolescent, but to the parent as well, that there is an end to the feeling and crisis. So kind of like what Alejandra said, this too shall pass. There is that end to the situation. And providing coping skills training. So anything that you know as a clinician, mindfulness, deep breathing, grounding. So anything that we know, we definitely want to let them know and train them and show them anything, because what works for one client may not work for the other. And increasing sessions. So we want to make sure that we increase sessions to 2 times per week or as needed. So definitely doing check-ins in between sessions. How are things going? Is there anything that's needed? But definitely increasing sessions is a must. And making sure that you don't complete a suicide contract. So as we already know, suicide contracts are not effective and are a liability to us as professionals. So creating a document that's like, I will not hurt myself, and having the client sign it is not going to protect you or the client. They're not effective and they're not going to do anything. So we want to make sure that we do something a little bit more thorough and helping the client in safety planning. And last but not least in here is documenting, making sure we document everything, not only for ourselves, but also for the client, and making sure that we're doing everything that we can to assist the client in remaining safe. Again, and as providers, we already know if we don't document, it didn't happen. So in the continuation of safety planning, when we're talking about a detailed written plan, that's definitely a must. Now, right now with virtual, it's a little bit of a challenge, but we do our best, and I'll get to that a little bit ahead. But definitely one of the things that we want to put is the warning signs and behaviors which cause concern. So what are the triggers? What are some of the things that are happening with the adolescent that can cause the suicidal ideation or the suicidal thoughts to come up? We want to list the diversion techniques or coping skills that can be used. Like, what are some activities that they could engage in? What are some coping skills that they can use? What are some phone numbers of people that they can call during crisis? So you definitely don't want to have them name their arch enemy in high school, right? Because they're not going to call them. You want to make sure that they have, maybe like a best friend, somebody that they can trust, an adult, someone who they can really feel comfortable with calling when something is happening. And you want to list the steps to removing access to lethal means. So if there's any weapons in the home, if they already said, well, I already know where my mom keeps the medication, and I already know that when I feel suicidal, I can go and get it and drink all the pills. We want to make sure we remove that access and list the steps to removing that access. And you want to list the mental health professionals that could be contacted. And something that I found really important to be a part of a safety plan is describing the motivations and reasons to stay alive. I've noticed that if this is listed, they kind of tend to really think about kind of what they're doing, because in the time of crisis, they don't really think about like, hey, why am I here? What can I look forward to? What is important to me? So I think writing it in advance is something that's really important. And including local emergency numbers. So 911, the hospital, the local police station. I mean, just like any local emergency numbers. Even 911, because even though it seems like common sense, sometimes I think when we're under crisis, we may not remember. And any hotline numbers that they can contact in between sessions, when they might feel like they're in crisis, in case you don't answer or they miss a phone call. And clients should complete in their own writing It's really important because I think it gives them more of a commitment, I think, to themselves if they write it. Right now, it's a little bit more difficult virtually, so we do what we can right now, but when in person, definitely the client should complete in their own writing. Okay. So we're going to watch this very short video, which I think gives us a little bit of a glimpse as to adolescents and kind of like what they feel. And sometimes I think it can provide us a little bit of an insight from their perspective.
I have my ups and downs, just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy. I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual,
Acting really down, crying all the time for no good reason.
or getting really mad, not able to sleep, or sleeping too much,
Shutting her friends out or giving her stuff away.
acting reckless, drinking, using drugs, staying out late,
Suddenly not doing stuff he used to love.
or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed. Not just feeling down, really depressed.
It might be that your kid is thinking about killing himself. It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to
I
me.
wish he'd said
I
something.
wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask. And they want somebody to care.
Maybe you're afraid you'll make it worse if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask. In fact, the best way to keep a teenager from killing herself is to ask. Are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes,
Well, here's what you don't say.
that's crazy.
Don't be such a drama
You're
queen.
making too much of this.
That boy's not worth killing yourself over. It's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself. What you do say is,
I'm sorry you're feeling so bad. How can I help? We'll get through this together.
Let's keep you safe.
a lot of people think about killing themselves, adults and kids. Most of them never tried, but some of them do. So if your kid says,
I'd be better off dead. Can't live with this.
I'm gonna kill myself, take her seriously. Or find someone she can talk to about it. Someone who knows how to help.
Sometimes kids want to kill themselves because something happened. A breakup, a failure. But sometimes it goes deeper, and it's not going to go away by itself. Get some help. Talk to your doctor.
Or a counselor at school.
Or your minister.
But don't just let it drop.
And make sure that your kid always has someone to turn to. Someone he trusts. Make a list together, right then. 3, 4, 5 names.
Put a suicide hotline number on there too.
Have him keep that list in his wallet, so he always knows where to turn.
Be sure your home is safe. If you have pills she could use to hurt herself, lock them up.
If you have a gun, don't just lock it up. Get it out of the house. Bullets, too.
And one more thing. If you think your kid might be about to hurt himself, don't leave him alone.
Take them to the emergency room.
Call 911 if you have to.
We all have our ups and downs, but sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask. Ask straight out. Are you thinking about killing yourself?
Don't wait until you're sure. Trust your gut, because it never hurts to ask.
And it can make a big difference. All the difference. In your kid's life.
Well, thank you for watching that video. I know it could be a difficult video to watch, but I think it's a very important video and something that could be very helpful. Moving on to some resources. So as we already know, the National Suicide Prevention Lifeline is one that we have always seen. So the 1-800-273-8255 is a 24-hour hotline that's available to anyone in suicidal crisis. But I think when we're talking about suicidal adolescents, we want to think about they don't really like to talk. So texting is a really good alternative for them. So there's also the crisis text line, and they can text EMM to this number, and they can text confidentially with a trained crisis counselor for free 24/7. And there's also the LA County DMH Access Line, which is a good resource for providing referrals, screening, assessment, and crisis counseling. There's also the Trans Lifeline, which is a organization that is dedicated to improving trans lives by responding to the critical needs of the community, and is available at different times of the day, and it's run by volunteers. And there's also the Trevor Project, which is a leading national organization which provides crisis intervention and suicide prevention services to lesbian, gay, bisexual, transgender, queer, and questioning young people under 25. And they also have Trevor Text, which is available by texting start to that phone number. And we'll definitely send these out to everyone. And there's also the teen line online, and they can actually call, text, email, and there's also a message board that they can utilize with other teenagers and ask questions. And there's an actual like community and online support. So I thought this was a really great resource for teenagers. And again, I think really encouraging them to reach out whatever way that is, if it's a phone number, but I think for them, something that's like texting would really work out for them, because that's just kind of like the era that we're in right now. And there's some references, and we will move on into Q&A. But thank you so much to everybody for tuning in to the presentation. So we'll take a few minutes for any questions that anyone has.
Hi, Daisy. Thank you so much for that wonderful presentation. I know it's a very sensitive subject, and it's not something that, people in general like to talk about, but it's so very important, especially now with the pandemic. We've seen with teenagers a high rise in incidence of suicidality amongst the youth. And we have one question in our comment section. Someone's asking, what advice would you give someone that has an adult friend or relative that's expressing suicidal ideation?
Well, I think it really just kind of depends on kind of like the relationship that they have with that person. It would really depend on how close they are to this person and how ready that person is to receive that information. Sometimes if they are close to that person, they are ready to receive, resources and referrals and things like that. And kind of like where they are in their process. But sometimes they're not. So I think it's really being able to evaluate how close is a relationship and how confident or able are you to help that person. And because I think the other thing we want to think about is, I know that sometimes we worry about wanting to help another person and worrying that they're going to get upset with us. And, if we refer them somewhere or we give them information, but I think we also have to think about, I personally would rather have them be upset at me for giving them that information than having something happen. So I think just really being able to share with them that we care about them, and that this is why we're sharing that information. That's why we want them to get help, that they can count on us for any assistance to keep them safe. So that's what I would say.
Okay, we have another question. So what advice would you have for adolescents who express suicidal ideation to their peers and tell them not to say anything to their parents or their family, which is something that does occur at times?
Definitely. I think, and that has happened before, in the clients that I've worked with before, they tend to trust their peers a lot. And it is really hard. I do try to tell them, like, hey, I know that you trust your friends and they are a support system for you. But I think also in having clients kind of be that holding space for them. We also want to, I think our as professionals and as adults, we want to make sure that their safety, is of utmost importance. So making sure that they're safe, we want to let them know that they can count on us. We want to make sure that, I think as clinicians, one of the biggest things that we go through is kind of like that, we don't want to break their trust,
Right.
but at the same time, we want to keep them safe. So I think kind of like the same concept as to like, well, we want to be able to have you trust us, but we want to keep you safe, and kind of like that same concept with the teens, and
Okay.
helping their friends.
Thank you for that. Another question. Let me see if we have any further questions. I have a few questions of my own. Is cutting or self-harm considered suicidal ideation or attempts?
Not necessarily. So there's also non-suicidal self-harm or self-injury. So I think really kind of working with your client and really asking, kind of like what the video said, right? Really asking straight out, do you want to kill yourself? Because sometimes in my experience in working with clients is they don't want to kill themselves. They just want to get rid of the pain, right? Of the emotional pain, and they want to divert their pain to something more physical. So sometimes it's not necessarily that they want to end their lives. They just want to divert their emotional pain to a more physical pain.
Mm-hmm. And I truly, appreciate the emphasis that you put on asking direct questions in terms of, suicidality. A lot of times, even as professionals, we tend to feel a little eerie about asking a direct question. But in reality, as the kids, stated in the video, it's not that you're going to implant a thought. That thought is already there. The direct question actually helps and puts them at ease that someone is actually, addressing the issue that's been lingering in their mind for a long time.
Mm-hmm. Yeah.
So I have another question. Teenagers, just working with teenagers for a long, long time, their behaviors are erratic at times, just because that's the stage of life that they're in. What or how can we differentiate between something that is a normal teenage behavior to, one of those warning signs that you were talking about in your presentation?
Well, I think that's where, as parents, we have to also be able to pay attention. And even though some of the things that happen with adolescents, children, and even adults, we are able to tell like when there's sudden changes and really like, like really sudden changes in the behavior. So maybe like sometimes they tend to be kind of like to themselves and everything, but they still kind of go out with their friends. But all of a sudden, they don't want to do anything. They don't want to talk to anybody. They don't want to engage with anyone. So really paying attention to more sudden, extreme changes in kind of like their behavior. And that's where really trying to keep an open communication with your adolescents is really important, I think. And kind of keeping that open line of communication is really helpful, because when changes like that happen, they tend to be a little bit more trusting of you as an adult to kind of come and tell you and say, hey, this is what I'm going through and whatnot. It doesn't always happen, but definitely kind of trying to be a little bit more involved in kind of like what they're doing, especially now with social media and having access to so many different things, definitely being a little bit more involved in what they're doing.
I agree. Thank you for that. And also, is comorbidity a factor in the risk assessment of the youth and suicidality?
Yes, definitely. So we want to think about sometimes there's already like depression and anxieties as underlying factors. We also want to think about like the predisposition, I think, hereditary stuff as well that are already kind of there and just, that are kind of, they're already predisposed. So they're definitely, the comorbidity is a big factor as well that we want to kind of like really think about, and is a big contributing factor to suicidality for adolescents and adults as well.
Right. And so going along with the comorbidity, it's also, there's that substance abuse piece, with that, and someone's asking, how does substance abuse affect suicidality, which is kind of alluding to the same thing, with the comorbidity.
Yes, no, definitely. When you're talking about substance abuse, we want to really think about also, like, is that also affecting even more like the depression, or is it like the depression leading more to more substance abuse and all of that? So we don't know what came first, the chicken or the egg, but I think definitely those come hand in hand a lot of the time.
Well, thank you so much, Daisy, for addressing such a sensitive topic and being with us here today. Definitely, if you have any more questions, you can put them in the chat and we'll try to address them. Thank you.
Definitely. Thank you so much to everyone. And if there's any further questions, we can definitely address them. Thank you.